Greetings, everyone. Welcome, welcome. How are you all? It's a beautiful April evening. I think that's where some of our numbers went, but I hope they're at home zooming in. So we have a lot of people on Zoom attending throughout the state of Colorado, as you know. So this is our last mini-med session for our spring semester, and our next mini-med session, which we'll remind you about, is October 2nd. Please be sure to register right there on that QR code. Tonight is my pleasure and actually my honor to introduce Kristen Furfari, who is like a hero to me. So I'm going to read her bio. I did it the best I can. I could go on for like 2 pages, but I have a little paragraph here. Dr. Kristen Furfari, MD, graduated from the University of Colorado School of Medicine in 2004, a year before me, and she's accomplished so much more. She received her Bachelor of Science degree from Creighton University, where she also then got her master's in medical ethics right after that. After graduating from the medical school in 2007, so if you went to 2008, wait, yeah, it's simple math. I can't do it anymore. You graduated. Okay, graduated. Okay. All right. So she went to the Colorado Family Medicine residency program, and she is now board certified in hospital medicine. She is affiliated with the University of Colorado Hospital in the Division of Hospital Medicine, where she is an associate professor. She's currently the director of the Health and Society curriculum for the School of Medicine, which is a major component of the new and innovative School of Medicine longitudinal and integrated curriculum, which kicked off in 2021. She's written most of that curriculum and is considered a lead medical educator, not only due to this, but because of her previous involvement as a director for the Foundations of Doctoring program in the previous curriculums and in the previous curriculum's advisory college program. Dr. Furfari is on the University of Colorado Hospital Ethics Committee and is a member of the Society of General Internal Medicine Ethics Committee. For our mini-med long haulers, some of you already have, many of you may recognize her in her previous role as co-director of the mini medical school. There's a lot more to say. We're absolutely honored tonight to have her close out our 2024 spring session with a presentation on ethical dilemmas in medicine. Please enjoy.
Make sure this is on. We good? Yes? Okay. All right, we're set. Okay. Well, thank you all for being here. Thank you, Joe, for that introduction. It's really fun to be back. Like Joe said, I've been with Mini Med School for a long time, pre-COVID, so it's fun to see how it's evolved post-COVID, and it's lovely to have all of you here tonight. So I'm going to talk to you about ethical dilemmas in medicine. Like Joe said, I'm a hospitalist. That's one of the hats I wear. And that means I take care of hospitalized patients while they're in the hospital. Once they leave, they go back to their primary care doctor, but I have the honor of taking care of them during their hospitalization. And then the other hat I wear is as a medical ethicist. So I'm the medical director of the Ethics Consult program at University Hospital. And what we're going to talk about tonight are some of the ethical dilemmas that I've encountered in the hospital through the ethics program. But I'm going to start with a story. This is my daughter. This was years ago. She is now 9, but this was when she was a lot cuter. And she's my first daughter. So being my first daughter, I really liked to dress her up. I liked to have outfits for her, and I would match them. And I would make fun of my husband when he tried to pick an outfit for her because he never picked a good outfit. So one day when I was on call in the hospital rounding, I get this picture from him, and the text said, "Did I do well today?" Now the double shoe thing was something that she did no matter who dressed her, so I'm not blaming him for that. But he thought that because he matched flowered pants with a flowered top, that she had a complete outfit. So my response to that text message was an ethical dilemma for me. So how does she look today? So if I said, "She looks great, honey, good job, really proud," then I'm not being honest, right? Then I'm not being truthful. And that is an ethical value: honesty, truthfulness. But if I tell him the truth, she looks ridiculous. What do you think she's wearing? Then I'm being unkind, potentially not loyal to my husband, right? And so this is a very, very simple ethical dilemma. These are the kind of ethical dilemmas that we all encounter every day throughout our lives, and we just navigate them. We'll put that picture up there. My husband's colorblind, so maybe we'll give him a little bit of kindness there. But that is an ethical dilemma. And really, ethical dilemmas, the word dilemma is a Greek word, di meaning two, and lemma meaning fundamental propositions. So it's really when there are two fundamental propositions that rub up against each other. And they're often very value-based. So the root of all ethical dilemmas is values. And when there are values that are in tension, that's when we end up with these dilemmas. Now, they're hard because when we come to an ethical dilemma and decide which path we're going to take forward, one of those values has to be left behind. I either have to be truthful to my husband or I have to be loyal and kind. It's really hard to navigate both of those values, and that's the dilemma part. Now, the word dilemma, when we think about it in today's world, we often think about it as something that has kind of a negative connotation. Dilemma, we think of as having two bad outcomes, but really it's not. These are often right versus right situations because they're value-based. So the values are right. It's right to be truthful. It's right to be kind. Both of those are right values. And we can think about some of the more difficult ethical dilemmas, things like, we're not going to talk about this today, but things like abortion rights, right? We could say it's right for a woman to decide what happens to her body. It's right to protect the lives of the unborn, right? Those are two right ideas, right values that come in tension and create these dilemmas. So we're going to come back to this idea of values throughout the talk tonight. And we're going to talk about these dilemmas that we encounter in the hospital. So our objectives, we're going to talk about the personal and professional values that are part of ethical dilemmas. We're going to discuss some of the core foundational types of ethical dilemmas that we encounter in the hospital setting. I'm going to share some cases with you. And then we're going to talk about how our ethics team approaches these types of ethical dilemmas. So let's start again with this idea of values. And this is where you all get to participate. So I'd like to hear from you. What are some values that you as an individual hold, or some values that you think are part of our culture? Now, these can come from your community, your personal beliefs, your profession, any of those places. What are some values that you hold? You can just yell them out. Love it. Honesty. Oh, we have honest people here. Thank you. Integrity. Okay, wonderful. Genuine. Very good. Inclusion. Oh, great one. Great one. I really like that one. Loyalty. Great. Wonderful. So these, we know these, right? We know that these are part of how we live our lives. And I put a list here. Obviously, there's hundreds of values we can come up with. But these are some of the ones that we see, some of the things that we see in tension in our hospitalized patients. We'll talk about some of these. So again, we all encounter ethical dilemmas throughout our daily lives. You are interested in reading more about this. This book is really good. It talks about ethical living. It really talks about these ethical dilemmas that we encounter as we go through our lives. And it breaks these ethical dilemmas into 4 categories. So again, values and tension. So truth versus loyalty. So that was the situation with my daughter and my husband, this idea of truth versus loyalty. Individual versus community. This one came up a whole lot during the pandemic, right? Individual rights. I don't want to wear a mask versus the good of the community, the good of the people I'm around. So individual versus community is a very common one. Short-term versus long-term. We see this in the medical students where they're questioning the value of giving up time with family, time with loved ones in the short term for the long-term goal of becoming a physician. That's a tension that our medical students often encounter. And then justice versus mercy. I think of this one a lot as a parent in disciplining my child, right? justice versus mercy. Things like some of the professional athletes who have used illegal substances and been banned from their sports. Justice versus mercy of allowing them to come back and compete at some point down the road. So again, as you encounter dilemmas throughout your life, you probably can put a lot of them into one of these 4 categories and think about the values that are at play. And we come across a lot of dilemmas in the hospital, again, value-based. Now, our values in the hospital are a little different, right? We have the idea of not doing harm, this idea of patients' rights, confidentiality, privacy, truth-telling, honesty, and then justice and fairness. And the hospital is also quite difficult because there's some unusual components in the hospital. There's a lot of hierarchy in the hospital. So there's hierarchy in terms of the healthcare professionals. So our medical students, again, feel this hierarchy. They run into dilemmas of not knowing how to proceed within the hierarchy, not knowing how to call out something that they may see or may worry about. There's also hierarchy between different types of care providers, physicians, nurses, social workers, physical therapy. There's some perceived hierarchies there. And then obviously between patients and healthcare professionals, right? Healthcare professionals have a lot of knowledge about medicine that patients don't have. And so that leads to this unequal balance and unequal knowledge that can create these ethical dilemmas. Confidentiality, privacy is huge in healthcare settings, right? As a physician, I'm privileged to a lot of really private, personal information about my patients. And I need to be respectful and thoughtful about what I do with that. And so that can lead to some ethical dilemmas. And then this idea of truth, we'll talk about a little bit. But truth in medicine is often very different than the truth that you perceive in other aspects of your life. As a physician, I think of truth as science, right? Science is facts. But for my patients, truth may look very, very different. And so again, that can lead to some ethical dilemmas. So the way we approach these dilemmas in the hospital is with ethics consult service or ethics committees. And I want to give you just a little bit of history about the development of ethics committees. So this is a picture of Karen Ann Quinlan. I see some nods, so some people recognize this picture. This is way back in 1975. So back in 1975, she was a teenager. She took pills and alcohol together, went to a bar and passed out, and she never regained consciousness. So the records say that she ceased breathing for about 30 minutes. She was taken to a hospital and put on life support and just continued to deteriorate. So her weight got to 70 pounds. The doctors described her as in a persistent vegetative state. So she had brainstem functioning, she had cerebellar functioning, but she didn't have any cognitive functioning. They said there was no hope of recovery. And so her family went to the doctors and asked them to remove the life support. They wanted her to die with dignity and grace, was what they were asking for. And the doctor said no. They said that there was no precedent to remove life support in this situation, that they couldn't in good conscience do that to her, and they were worried about a lawsuit. So they said no. And this went all the way up to the Supreme Court. And what came of this that's important to us tonight is the idea of an ethics committee. So the court ultimately decided that her father could serve as her proxy decision maker, could decide what happened to her healthcare. He asked the physicians to remove her life support. She lived another 10 years and died in a nursing home at the age of 31. But the other part of the court ruling was that the courts recognized that it would be unnecessarily cumbersome. That was the word they used. Unnecessarily cumbersome for them to have to be involved in every ethical dilemma that arose in a healthcare setting. They recognized that the lawyers and the judges did not have sufficient medical knowledge to be able to appropriately determine the right course of action. And so they pushed this down to the healthcare facilities and suggested that there be ethics committees created within the facilities to help navigate these ethical challenges as they arose. And so over the course of time, that led to ethics committees. In 1992, the Joint Commission, which is the credentialing body for hospitals, created a mandate that said that all hospitals need to have a mechanism for managing ethical conflicts. Mechanism is their language, which obviously is very vague and doesn't tell hospitals quite what to do. But a lot of hospitals interpreted that to mean that they needed an ethics committee. The last statistic I saw was that something like 98% of all hospitals in the US, academic and community, have some form of an ethics committee. So this is prevalent. Any hospital you go to should have this. And if you remember nothing else from our talk tonight, the one thing that I want you all to remember is that anybody can request ethics consult involvement in a hospital. So you don't have to be a healthcare provider. You don't have to be part of the healthcare team. You can be the patient, you can be the family, you can be the friend. Anytime someone's in the hospital and there is this value conflict, these values in tension, and you want help navigating that, you can ask for an ethics consult, and the healthcare team should be able to provide you with some form of ethics support. Okay, so please remember that. We don't get very many consults from patients and families, and I think a lot of the reason is because people just don't know that this is something that they can ask for. So hospital ethics committees, like I said at the beginning, I'm part of the consult service at the university, and our role is to navigate these dilemmas. So when there's two or more values in tension, two or more valid outcomes, these right versus right situations, when there's uncertainty and it's unclear what to do. And then we often get called with these questions of moral distress. And moral distress is the language that we use to describe a situation in which there's a clear right course, but there's a barrier preventing us from doing it. So things like a patient who should be discharged to a rehab facility, but doesn't have the financial resources to do so, and so gets discharged somewhere else that doesn't meet the needs that they have. So that leads to moral distress, and oftentimes ethics is involved in those situations. So our ethics committee, ethics consult service at the university hospital is multidisciplinary. We think that's really important. We think it's essential that we have people with different backgrounds wearing different hats looking at a situation. So ours is me as a physician. I have a social worker. I have a PhD ethicist. I have a chaplain. So spiritual care is part of this. And then I actually have a researcher on ours as well. So it's multidisciplinary. Every time we get a consult, the first thing we do is we name those values. We often are asked to clarify laws and policies to guide healthcare in appropriate ethical ways. And then what we do at the end of our consult is we make a recommendation. And this is different than the recommendation the healthcare teams get from like the cardiologist. The cardiologist will say, here is the medication you need to give, here's the dose, and here's when you give it. Ethics obviously does not do that. So we give a recommendation that can validate these different avenues, again, depending on which value is going to guide the direction. So we will often say it is ethically justifiable to do this. And sometimes we'll say it's also ethically justifiable to do the exact opposite, right? Because these are right versus right situations. So really what we do is we try to guide the team in making the best decision possible along an ethical course. So let's talk about some of these cases. Now, last time I gave this talk, I didn't tell the outcome of the case, and people didn't like that. So this time I'll tell you how the case played out at University Hospital, but I want to remind you that just because that's how it happened at university does not, does not mean that that's the only right way, right? These are right versus right. There are many different ways for these cases to play out in an ethical manner. So this first case is an elderly woman. She lives in a nursing home. She was outside walking with her caregiver. She uses a walker, and she passed out pretty quickly, pretty suddenly. So they called EMS. EMS came, and when they evaluated her, they recognized her to be in an arrhythmia, so an irregular heart rhythm. So what happens when your heart isn't beating regularly is that it's not able to pump the necessary blood to all the organs in your body. If your brain doesn't get the blood, the oxygenated blood it needs, then people pass out. So it was presumed that she passed out because of this arrhythmia. So EMS put an external pacer on her. So they essentially placed a pacemaker externally to regulate her heart rhythm. They took her to the hospital. And in the hospital, they called her family. Her family quickly came, and they came with an MDPOA paperwork. Does everybody know what an MDPOA form is? I think this is probably the second most important part of this talk. So this is the second thing you must remember is please everybody have an MDPOA. So an MDPOA is somebody that the patient has designated to make their healthcare decisions on their behalf if they are unable to make their own decisions. Okay, so it's somebody that you designate to make your decisions for you if there's a situation in which you can't make your own decisions. This patient had as an MDPOA, it's one of her family members, and the family member says, no way, take that external pacer off. We're not going to place an internal pacer. This is not what she would want. We're not doing this. And so ethics in this situation, ethics was called by the cardiology team. So CARD said, hey, we don't know what to do. A pacer is not that big a deal. This woman falls again, she could bleed into her head. She could break her hip. There's a lot of morbidity, potentially mortality associated with an arrhythmia in someone of her age. We can fix this. The family is saying, no, we don't feel okay about this. What do we do? So we're ethicists. So what are the values in tension in this situation? And again, feel free to yell them out. What values are in tension here? Ooh, good. What the patient wants. What's the ethics word for what the patient wants? Do we know that word? You do know that word. We'll talk about it in a minute. Good. So what the patient wants in tension with what? Yeah, exactly. So what the community, what the physicians think that she should have, what's the right choice from a medical standpoint. So this really gets at this idea of beneficence. And then the other word people do not agree on how to say, non-malfeasance or non-maleficence. Take your pick. Nobody's in agreement there. But this is the idea of doing no harm, doing good for the patient and not causing harm. So this is the bedrock of medicine, right? It's part of the Hippocratic Oath, this idea of do no harm. And it really does guide decision-making. But what we need to know in this case is what is harm for this patient, right? What is harmful? And so that's where we need to better understand what's guiding the decision-making. So the patient's family communicated that she was previously independent. She'd really been struggling since going to this nursing home. She'd been declining, not really been able to do her activities of daily living independently like she wanted to. And they thought that any medical intervention would just further cause decline and would not be aligned with how she wanted to live the end of her life. She didn't like being in a hospital. She was scared in hospital settings, and they didn't want to subject her to that. Okay, so that's what the family is saying is beneficent to this patient, right? And then we have the healthcare team saying, but no, a pacer is beneficial to her because she won't have an arrhythmia anymore. So that's the uncertainty, the tension here, right? Short-term good, we know we can place a pacer, we'll fix her arrhythmia. There's a short-term good, but what's the long-term good for this patient that doesn't equate with any improved quality of life per her own metrics? And then again, this idea of biomedical good. This is what the physicians know as good versus the value aligned good, the good as expressed by the patient. So in this case, there was more of a one right, ethically appropriate avenue. So ethics guided the team in honoring patient wishes as expressed by the family. And the team talked about ways to support her to support her health and well-being without a pacer? What would that look like? Were there any other supports, any medications, any other avenues that we could provide to help support her without doing the pacemaker? So that was one of these cases where patient choice, this is the word, autonomy, right? So we talk a lot about autonomy in healthcare, patient wishes. And we put this really at the highest in terms of guiding decision-making. We really want to align our decisions with what a patient would want, a patient's autonomy. But even autonomy leads to ethical dilemmas. So we have dilemmas between patient and providers, in the case we just talked about, patient autonomy versus what the healthcare providers think is beneficent. Sometimes we have patients who don't have decisional capacity, who can't express an autonomous choice, who cognitively are not able to reason through a decision. And that's where your MDPOA becomes essential, because those are the people who will make decisions on your behalf. The word unbefriended, I think it's a terrible word to describe a patient, but an unbefriended patient is somebody who doesn't have decisional capacity and has no healthcare decision maker, has no MDPOA, has no friends, family, interested parties who can make decisions on their behalf. Colorado law actually allows for an independent physician to make decisions in these cases as a last resort, but that really pushes up against the idea of autonomy. What about when a patient makes what we would consider a bad choice, right? I guess you could argue that for the healthcare team, choosing to forego a pacer was a bad choice. We have patients who choose to discharge to a place that we don't think is necessarily the safest, or patients who don't want to participate in some of the medical interventions or treatments that we have to offer that we think can cure them. So bad choices through the eyes of the healthcare team, not through the eyes of the patient, right? And then obviously we have situations in which there's unclear patient wishes. So autonomy can lead to dilemmas as well. Let's look at another one. This is an 83-year-old. The dilemmas are not all with older people. I should have probably mixed these up, but we're going to start with these older ones. So 83-year-old, she lived at home, lived independently, and fell over a rug, had a little area rug, fell over it, landed on her hip, and caused a right hip fracture. So she came into the hospital, and she is actually quite healthy, no significant other medical problems. Orthopedics evaluated her and thought that the best approach would be an operative approach, so surgical correction of this hip fracture. And when she came in, she got a physical exam, and they noted that she had a new heart murmur. So as part of the workup for her surgery, they got an echocardiogram, so an ultrasound of her heart, and it showed aortic stenosis, severe aortic stenosis. So the aortic valve is the valve that, the door that allows blood to go from the heart out the aortic arch and down into the body. And when that valve gets stenosed, when it gets closed down, the heart is not able to be effective in pumping out blood. We know that aortic stenosis can cause perioperative cardiac mortality and morbidity. So it's actually up to a 40% increase of post-surgical cardiac complications when a patient has severe aortic stenosis. So that's pretty big. That's a big deal. So the anesthesiologist goes to consent her, and the patient says to him, I don't want to know. Don't tell me. Just do the surgery. I can't imagine not being able to walk again. I want to be able to go back to my home. I don't care how dangerous this is. If I die on the table, I die on the table. Go forward with the surgery. Don't tell me anymore. And the anesthesiologist called ethics because they said, oh my, I don't feel like I've done a great informed consent. I don't feel comfortable moving forward. I don't feel like I've been able to fully explain the risks. What do I do? What are the values here? Yeah. Yep. Patient autonomy. What's the value that the physician, the anesthesiologist, is expressing? Honesty, do no harm. Very good. Yep. Very good. So this gets also at this idea of informed consent, right? This very, very critical part of healthcare that we provide. So for informed consent to happen, there has to be information shared. Colorado law has a reasonable physician standard, meaning that the information that needs to be shared for the consent process is what a reasonable physician would consider to be sufficient information, whatever that means. That's the standard we use. Lots of other states have a reasonable patient standard, which makes a little more sense, I think, but we have a reasonable physician standard. So the anesthesiologist is saying, no way, definitely did not, I was not able to share enough information that I feel like I've done reasonable physician information sharing. There has to be capacity. So the patient has to be able to have capacity to cognitively reason through the decision. And then the decision needs to be made without coercion. So those three elements are necessary for informed consent. So did informed consent happen here? The anesthesiologist is saying no. So this case was a tough one. Because we understood the values that the patient was claiming, and that we have an obligation as healthcare professionals to perform informed consent. And so the way this one landed, the team talked to the patient's best friend, who was her proxy decision maker, and used that person as part of the informed consent process. The patient, because she had capacity, ultimately did make the decision to proceed with surgery, but the team felt as though if they were able to talk to her proxy, that felt like at least somebody in this patient's circle was getting the information that they thought was important to know. So that's how this one moved forward. I don't know, is anybody a lawyer in here? Okay, good. From a legal standpoint, probably didn't meet all the criteria of informed consent, but is that ethically justifiable to move forward that way? Absolutely. Absolutely. This patient actually did really well. Did not have any complications from her surgery, went to rehab, and then was able to go back home. So this one had a great outcome. This one, 28-year-old male, history of alcohol use disorder, long history of alcohol use disorder, but had been sober for a couple years, admitted with withdrawal. He came in, he was very open, very honest with his story, but asked that his information not be shared with his family. He was currently living with his mom and his sister. They had a tenuous relationship, and they had told him that if he ever drank again, he was going to get kicked out of the house. And so he was really worried that if the healthcare team disclosed this information, he'd get kicked out, he'd have to live with friends, and his friends were what caused him to drink, or they drank. And so he was worried that he would further relapse if he had to go live with his friends. So the healthcare team, actually, they described walking out of the patient room, going around the corner, and then mom and sister are right there and say, is he drinking again? Is he hospitalized for alcohol? So they said, we'll get back to you. Went and called ethics. What do we do? Okay. This gets at this idea of confidentiality, right? Confidentiality in the hospital is obviously extremely important in terms of developing trust. And there are very clear exceptions to confidentiality on a policy level, right? As a physician, I have to disclose certain communicable diseases, like TB. I would have to disclose that to the state health department. I have to disclose if I have any concerns about abuse, so child abuse, elder abuse, vulnerable adult abuse. I would have to disclose if I'm worried about a patient's danger to self or others, right? So the state has decided in those situations that the well-being of the community outweighs confidentiality, patient confidentiality. In those situations, this is clearly not one of those situations. So what do we do? Are we doing good for this patient by keeping this from the family or by disclosing this? This one actually, the family guessed. And so we helped script some dialogue for him to have with his family to disclose it to them. So it worked out okay. They didn't, as far as we know, did not kick him out of the house. But there was a lot of tension in that room. And again, this idea of truth. What is truth? Truth for us as healthcare professionals can look very different than truth to the patient. And we really need to understand a person's definition of truth. All right. 65-year-old comes into the hospital. He's a GI bleed. So he's bleeding from his gut, from his intestine. And they do imaging when he comes in, and there's a very big mass that's thought to be the cause of his bleeding and most likely cancer, most likely malignant. His son is at the bedside. His son's a nurse and saw the imaging report, guessed right away, this is most likely cancer, asked the team to come outside the room and said, don't tell my dad that it's cancer. Tell me. I want all information to go through me. I don't want you to talk to him at all about his healthcare. I want it all to come through me. I'll tell him what I think he needs to know. Patient has capacity. Good question. Good question. I need to include that. Yep, patient has capacity. Good question. My ex-social worker knows the answers here. Yes, so this patient is actually from a culture, the son described that in their culture, that disclosing diagnoses like these that have a poor prognosis is seen as harmful. It takes away hope. And that hope is necessary for healing. Hope is a necessary part of getting better. And so in their culture, a family member typically is the go-between and gets all the information and then just shares that information that they think is necessary. So this is very cultural for this family. The healthcare team was very uncomfortable with this because the patient had capacity. The patient was able to make his own decisions. So when we round on patients, we often talk about their healthcare needs at the bedside with the patient right there so they can hear that conversation. So the healthcare team felt as though they really couldn't have that dialogue with the patient, couldn't really hear patient values, patient perspectives, because they weren't able to talk to him about his diagnosis. Good question. Good question. What do you all think? So I'm sorry, I should repeat that for everyone. The question was, did you respect the cultural sentiment or did you disclose to the patient? So good question. So we're going to talk about legal in a minute. Could you get into legal trouble if you don't disclose to the patient? So it depends. It depends. That's always a good answer in ethics. It depends. And the legal lens is absolutely one of the lenses that we use, but it's not the only one in ethics. So we will talk about the law here. So yes, we need to think about what's our legal responsibility. What does the patient really know? And this idea of patients are smarter than we give them credit for, I think is also a really important piece. Did this patient know? So in this case, the team actually did not disclose to the patient. The team had the conversation with the patient's family and let the family decide how much he needed to know. It got a little hairy because one of the treatment options was surgery. And the team got real uncomfortable with the idea, again, of informed consent for a patient who wasn't aware of the whole situation. Where we landed with this was that while the patient had capacity, we respected his wish to have his son be the decision maker. And so that's was kind of the ethical approach, that this patient with capacity chose to have somebody else make his healthcare decisions for him. So 18 is typically what we use as an age cutoff. Some states have a mature minor law that allows younger children to participate in their healthcare decision. Colorado does not, but for minors, it gets a little different because they can assent. They can agree to decisions while they are not fully able to consent. So another one about disclosure and confidentiality and truth-telling. This woman is 35 years old. She has AIDS. She's had it for a while. She knows this diagnosis. And when she came in, she said, do not tell anybody. She is from a culture, a community in which there is a lot of stigma associated with AIDS. And she's worried that if this is disclosed, that she will be excommunicated or less involved with this community. She describes this as what is most important in her life is her family, her community, her people. And so she did not want this revealed. So the team said, okay, fine. But then she got sicker and she developed encephalopathy, which means that she cognitively, she became confused. She lost the ability to make her own healthcare decisions, and her brother was serving as her proxy. So the team called and said, do we need to tell the brother? Does the brother need to know in order to make healthcare decisions on her behalf? So law, this is where we get into the law. So the one slide that I have here on the law, I just want to acknowledge that ethics and the law are different. Okay, the legal perspective is important, and we have a lawyer actually as part of our broader ethics team because we need to know that dimension. But there are some times where ethics and the law do not agree. The law is very clear in many cases, but it's a broad picture of how to act broadly. It does not necessarily well apply to these individual cases where there's culture and personal values and family beliefs, right? Those situations, law does not factor that stuff in. And so that's where ethics can come in and help guide the decision. So my lawyer friends know that sometimes our recommendations are not necessarily what the law would tell us to do, but are ethically justifiable. And so really where we go with this is we want to understand the patient's voice, right? That's where we're coming with all this. We want to know their story. We want to know their values. We want to know how they are making their decisions. What's guiding their decision making? That's what we do in ethics. And I really like this quote by Mr. Rogers, this idea of understanding a patient's story, even when we have these very difficult patients or these very difficult dilemmas, that once we get at the patient's story, it becomes a lot clearer and values become really essential. So this is my last case. And this is the case that actually took me into ethics. So I was an intern. So my first year of residency when I had this case. And this ethics team came and they helped guide this. And I thought, oh my gosh, that's so cool. I want to do that too. So this is Judy. Judy is 62 and she has Huntington's disease. So Huntington's disease, it's an autosomal dominant. So it's inherited through families. And it's a disease where there's essentially death of the brain cells. And it causes loss of movement, causes jerky movements. People lose the ability to walk, to feed themselves, to talk, to live independently at all. It's progressive. There is no cure. And at its latest stages, people develop dementia. This is a terrible, terrible disease that runs in families. Judy has fairly advanced Huntington's disease, and she came into the emergency department after a suicide attempt by overdose. So her family came home from a day out, found her in the bathroom, on the floor, pill bottles next to her, and called 911. When they brought her in, they intubated her to protect her airway, but she recovered fairly quickly. They extubated her after 24 hours and put her on a mental health hold because she was suicidal. Psychiatry was called to help guide the care because of this suicide attempt. And this is where we get in the tension. So Judy's mad. When she wakes up, she is mad. She's really upset that she was resuscitated. So she actually had advanced directives, and she'd made them 5 years earlier, and it was very clear in there she would not want intubation, would not want resuscitation. But that's what happened to her. Her family knew about these advanced directives, but they described seeing her on the floor and feeling this especially the son-in-law, this obligation to call EMS. The son-in-law was in law enforcement, and so he felt a professional responsibility, but the family all described this responsibility to do something. EMS arrived, and what do? They err on the side of saving people's lives. So she was resuscitated. Psych saw her, said she has capacity, she can make her own decisions. She's depressed, and they offered antidepressants. She said no. She said, let me go. The minute that I leave this hospital, I'm going to try again. She was very worried that with her progressive disease, she wasn't going to be able to physically take the pills if she waited too much longer. And she felt very strongly that this was something she wanted to do. She didn't want to have to involve anyone else. So I'm the intern, and she's telling me I'm going to kill myself the minute you discharge me. And I thought, oh my gosh, what do I do? So I called ethics. And so ethics came. They crafted this really great ethics question, right? Do we commit this patient against her will for inpatient psych? Or do we honor her autonomy? Do we discharge her despite this expressed suicidal intent? And so we got into the narrative. So Judy had Huntington's for about 7 years. She had family members, many family members with this disease, had watched them all go through this. She did not want to be a burden on her family. She described not wanting to live the end of her life like she'd seen her family members do. I might add, this was before we had medical aid in dying in Colorado as well. So there was no other options for her at that point in time. She'd been, she tried all the therapies, nothing was working. She was getting worse. And she said, I've lost who I once was. I know I'm never going to get that back, and I'm done. She had a bucket list of things she wanted to do, and she and her daughter had done them. They went to Alaska, they went to Hawaii, they did all the things. And she said, she was really eloquent. She said, I want to exit stage left before I cannot do this on my own. So ethical lenses here. Judy, she wants autonomy, right? Please let me do this. Her family, they also want what's good for her, but that's intention for them with this obligation, right? This professional obligation or personal obligation that they felt when they saw her on the ground. And then healthcare providers, beneficence again, right? We want to do what's right for Judy. What does that mean? How do we navigate this? And so the decision was that because she had capacity, she could demonstrate autonomous decision-making, and this suicidal ideation was chronic, meaning that it was related to her Huntington's disease, which is never going to go away, that we could not change her thought process, and it was unlikely that inpatient psych would change her thought process. That seemed harmful to her, given that she didn't have a lot of time left. She didn't want anything else, didn't want any other help. So we discharged her, and the social worker found her obituary in the paper just a couple weeks later. So in conclusion, ethics teams we're here. We want to help. We want to help navigate these situations. We're available to every one of you at any time. That these dilemmas that we encounter are really often right versus right. That when ethics involved, it's not because somebody is doing something unethical, but because it's really hard to navigate these value decisions. And we got to get at the root of the values in order to navigate this. And we really need to understand that patient's story. And I think what we do is really important. I'd like to think that ethics involvement in the case of Judy upheld her autonomy and really allowed her to live the end of her life like she had hoped for. And then I like this quote. The essence of being a caring clinician is working with patients to help them achieve the life they want to lead. That's it. We are consultants in the service of people. We are the experts in medical science, and patients are the experts in what's important to them. And that's really what we try to uphold in ethics. So thank you. Thank you.
I just have to say, you're right and right. That wonderful ethical, lecture that you presented now
Thank you.
also tells us that you're not only right in most situations, but you're also very nice. Thank you. Thanks a lot. Yes, we'll be taking questions, no? Yeah, whoever would like to. Is that? Sorry, that's my ethical dilemma.
Right and right, exactly. You got it.
In the last example that you presented, the lady with Huntington's, if she had agreed to sign into hospice care, do you think a hospice agency would have accepted her, knowing that she might be going
a
to
Good
attempt suicide?
question. Do you have an answer for us?
Yeah, kind of. So do I do this? It depends on which hospice. Can you hear?
Yeah.
Huh.
Yeah.
Yeah, it depends. There's one in town that will do this. And I know this because my good friend and old supervisor did this.
Hmm.
Yeah.
Yeah, I mean, I think hospice would have been an avenue for her. I think, she was just very set on what she wanted and how she wanted to do it. And so was not really open to thinking about other options that may exist. And there were a lot of them. I think today's situation would have been very different with the option of medical aid in dying, although that process is somewhat lengthy. And she was quite concerned about the progression of her disease.
C. For the father with possible cancer, how did you know he wanted his son to determine what he should know? What if the father didn't hold the same cultural values as his son?
That's a great question. Oh, it's another lovely ethical dilemma. So, so the team did have a conversation with him, and did ask him, what do you want us to tell you? Do you want us to use your family? And he did express that. I think the challenges in these situations when there is a community or a family belief are really hard. That just because a patient is a member of a certain community and member of a certain religion, a certain culture, does not mean that they hold all those same values. And so we cannot make assumptions. And I think that's what that question is getting at, that we really have to hear it from the patient, because we cannot stereotype people into these choices or these decisions or these values. We have to hear their expressed values. I think if that patient had lacked capacity, had lacked the ability to make his own decisions, and we would be left with using the family, using the son to guide those values. But in that case, fortunately, he did have that ability, and so was able to communicate and express that to the team.
Okay, I want to go back to your last thing again.
Yeah.
Somebody I know has signed the paperwork to take her own life due to the new Colorado law. And she did it and it was okay for her. Does an ethics committee, not necessarily yours, but does an ethics committee have any input into this?
Really good question. So not in individual cases. We are not a part of individual decisions about medical aid in dying unless somebody is concerned, unless there's a question. Ethics was involved in the creation of the law. So from that standpoint, yes, there are very, very clear guidelines about which patients are appropriate for medical aid in dying, the process by which it needs to happen. For medical aid in dying in Colorado, a patient has to be able to self-administer. So again, for Judy, that might have been a challenging thing. Had she had to wait, you need to see your primary care provider a couple of times with some duration of time between that. And so it really does prolong the process for people who have a progressive disease. But we're not usually asked about medical aid in dying cases. It's usually fairly clear. Good question.
How would one handle administering Narcan to an unconscious, overdosed, defriended narcotics addict that got violent because they wanted to commit suicide?
Okay, that was a lot there. So, I think the unbefriended part means, again, that a patient doesn't have capacity and we don't have anybody to speak on their behalf. And when we have those patients and we don't know, we always err on the side of saving life. We want to restore their capacity if we can, so we can have them tell us their story, so we can hear their values from them. So in that case, we would do what we needed to do to give the Narcan to stabilize the patient and to help restore capacity. Sometimes that requires restraints, whether it's physical or chemical, so medications or physical restraints. And in those situations, we will use those temporarily in the short term, again, with the bigger goal of trying to hear what the patient wants us to do. We often are called actually in situations of restraint. That's understandably a very uncomfortable situation for healthcare providers, and we're having to restrain patients. And so ethics is often involved in determining an ethical approach to restraining a patient who is violent.
So years ago, I was working in a rural health facility, and a child was involved in a bad accident and was losing blood. And because we didn't have blood at our facility, we transported this child with his folks to a hospital in Albuquerque. And the sad part was that the parents' religion forbade blood to be given. And so this child ended up dying. There was not a dry eye in the house because they really tried to convince the parents to follow through with saving their child's life, because it would have saved his life. So how often do you come across those kinds of situations where religion plays a big role?
Definitely. I mean, religion is one of the reasons that people have the values that they have, right? That definitely guides people's values. In the state of Colorado, you can't martyr your child. So in the state of Colorado, that would have had to go through the court system for the parents to make that decision on behalf of their child. Colorado would have given blood. But I think certainly religion is huge, right? We have patients who, for religious reasons, choose not to have blood products, choose not to use certain medications, vaccinations, right? That is a huge component of people's value systems. And when the patient is an adult and making an autonomous decision, we do honor those. I think where it gets hairy is in those situations in which there is potential harm to the public. So vaccines is an example where people used religious reasons to try to avoid being vaccinated, which is a decision that impacts not just them, but a bigger community. And that's where I think the ethical dilemmas get really complex, because it is impacting not just that person, but potentially many, many others. But as much as possible, we do honor patient values as expressed by religions.
Thank you, Dr. Furfari. It's just beautiful. Thank you so much for presenting
you.
this today.
Thank you. Thank you all for being
Very
here.
fortunate. In conclusion, I just want to let you know, I have to read this out. I mean, this marks the end of the spring semester for this session, the mini-med session. The fall semester is scheduled to begin on Wednesday, October 2nd, 2024. We encourage you to share this unique learning opportunity with your family, friends, and coworkers. It's never too late to register. Thank you so much again for being here.